I want to start by asking, everybody talked about sizing. How do we size? Start to the panel from the left to here.
So I think sizing is really important. I don't use IVUS. I will use stent tape almost in every one of these cases. I don't think that's always the most accurate, but I do, when a lot of these cases, what I will do is I'll get an idea from that stent tape, and I usually start with underinflation to dilate one of these lesions. So it's very common to start with a 4 millimeter balloon and then go back up to whether a 5 or 6, and then from there decide what I want to do. A lot of times with drug elution, I want to get to 1-to-1, but I don't go directly to that 5 or 6 millimeter balloon. So I size it almost on the fly. So I don't know if that's the right answer, but that's what I do.
Okay, thanks.
I also don't tend to use IVUS, but I do tend to use the roadmap. And when I have the roadmap and I go up with the balloon with the roadmap, it gives me an idea of whether the balloon size is similar to what the patent vessels or whether or not it's how severely undersized I am.
Thank you. Next. Any other ideas?
I use the exact same approach. I'd say I'd use intravascular imaging probably 20% of the time for sizing, but otherwise I use external tape and look at the size of the balloons and use undersized balloons to start out to estimate the ultimate size that I need to finish with.
Mehdi?
I mean, I think the interesting question is that, every device we have discussed this right now, we have shown that there's a significant differential in patency if you are elongated, if you're undersized. We saw it with Viabon, we saw it with Supera, we know that with DCB. But yet I am also like these guys. I don't use IVUS, and I, kind of tailor it to the device. With Supera, I don't want to oversize because I don't think you can get the rings out, and you put yourself at the risk of interception and elongation and getting into trouble. With DCB, I don't worry about that, so I tend to be a little bit more aggressive. But again, I guess the question is that why don't we use IVUS, given the differential in patency? I mean, we were discussing this morning with Dr. Pena in one of our conferences in the other room. I mean, the differential is 20-30%, the differential at 1 year. Mm-hmm. I mean, what are your thoughts? I mean, Matt and, in regards to why don't we use more IVUS? Is it reimbursement? Is it we are lazy?
Yeah, I think that's an important question, and I think there's a lot of cost considerations that go into these cases, and that only is going to be more and more scrutinized. And Steve, you talked a little bit about the Salisbury analysis of DCBs, and there's a lot of factors that go into making these procedures cost-effective and getting a great result for patients. And frankly, I think there's going to be a lot more interest in kind of following those health status outcomes for patients, and to Dr. Pena's point, making sure that we're not only getting good clinical characteristics and features and outcomes, but also the patients are benefiting from it. So
really, in my case, when I use Viabon, I use IVUS because I know it makes a difference a lot, especially if you use it for aneurysmal disease, because the enfolding will cause occlusion most of the time. But it's out of laziness and also cost, because $1,800, it's a lot of money to add to a procedure. Right. Open other questions?
Yeah, please feel free to approach a microphone if you have a question, but I'd like to ask Dr. Pena a question about kind of CLI and your comfort level in using drug for these patients, whether it's on a balloon or a Zilver, and how you approach a critical limb ischemic, and how aggressive are you with drug-coated technology?
So I knew that would bring up a question. I'm very comfortable with drug-eluting technology in CLI patients. I find that my CLI patients are usually older, and the long-term patency of that SFA intervention, I think, is critical in terms of the long-term of that particular patient. And I think that when you look at 2-3 year data, a lot of these lesions are going to be calcified. There could be very long lesions in these patients with Rutherford class 5 disease. I find myself stenting these more than just using a drug-eluting balloon. I think in that patient population, I use, it's because I think the long-term value of the scaffold. And I don't know if the data is there to back me up. I mean, I think you're going to see, there's a real world, a real PTX data that's going to come out comparing, that's 2 years in, and at Link we should get 3 year data. But get an idea when is there some separation at 2 or 3 years with a scaffold versus no scaffold with drug? And in that patient population, that the reintervention rate is high. I don't want it to be because of my SFA treatment, and that's why I go that way. You know, in a claudicant, and someone else said, I don't want to leave metal in, I don't like leaving metal. But in that potential, in that patient, especially in the right anatomy, I'll go ahead and go with that.
Thank you. Introduce yourself, please. And you, Robin.
Tayo from Dallas, Texas. Just thanks again for just an incredible session this morning. I want to ask about the drug-eluting balloon technology. We have 3 technologies on the market right now, and we're hearing about differences in drug dose, delivery mechanisms, and perhaps even patency rates. Do you think there's a difference between the 3 balloons that are on the market?
Go ahead. You want to tackle first? Go ahead.
Sure. I don't think that there's data available to suggest that there's a definitive difference between the 3 different available balloons. That being said, I favor one because the data from that randomized clinical trial demonstrated a slightly better target lesion revascularization rate, and because of that, impact is the balloon that I typically use in our cases. But again, I don't think the data is definitive yet.
I totally think you can't compare one of those studies to the other. Unless you have a head-to-head trial that's really well controlled, I think you can't compare them. And I think there's obviously a class effect, and we use a drug-coated balloon, and we say here all the time. But in that class, there's probably going to be differences. And how do we assess those differences? I am not sure. That I can't answer. Same thing is going to happen in drug-eluting stents when they come into the market. I'm sure there are going to be differences. And unless you have a comparative trial, it's very hard to really make that decision. That's why I think that when you look at the Imperial trial that's actually comparing head-to-head, it's going to be very interesting.
Yeah, I actually don't feel that way. We want to have some controversy here. So I actually don't feel that way because I believe that, we don't have that many head-to-head studies. No. And if we're just going to wait for those, we may be making some wrong decisions. So in my mind, I think you have to look at the collective data, and then you as a physician have to analyze the situation and see what it is. So the way I look at it is that both studies are done in claudicants. It's not like one is done in CLI, the other one is done in claudicants. The lesion length are very similar. The degree of calcification is the same. So and they were done in the similar patient population in the United States mainly and Europe. So to me, if the patient characteristics are similar, the indication for using the technology is similar, and there is a significant, it's not a little bit of difference. At 2 years, there is 20%, 25% difference in patency at 2 years. So it's hard for me to say that, that I can't just hide that data and say that doesn't exist. Yes, ideally, I'd like to have everything randomized against each other, but we don't have that. And so you have to use, in my mind, you have to use, your whatever is available to you to make the decision. And for that reason, we currently use the device that has the best patency in our institution.
So I never really think conflicted with Mehdi, but I will. And that is that I disagree in that I think you have to use the data that you have, and you have 2 sets of data. You can choose on that, but it's very hard to say that one is better than the other because I can just see it in my site. In my site, we have 8 investigators. And you may come up, and someone comes up to you, and you're seeing a patient in the office, right? 6-month follow-up or 12-month follow-up. If you're not blinded as to whether the patient got drug or didn't get drug, I can tell you out of our 8 people will treat that patient differently. So you may look at the ultrasound and say, oh, I got to treat. And I look at the patient, and the patient's not claudicating and doing well, I'm going to pass. And some people, and it's been shown that when you're on a trial, may treat that differently. So just the fact that one of them was blinded, one wasn't, I think is important. The amount of stenting, I think, is important. I mean, that's why I think real-world data is also very helpful in making these decisions.
And also, I think that there is the design of these studies. I mean, in one trial, they undersized because they were trying to avoid dissection. In the other study, they actually, they try to oppose the vessel wall. So also the design of the studies become important. I mean, that's why it's so important for the companies to do at the design level, to do the right design, because you could have a good technology, but if you do the wrong protocol, you set up the wrong design, you could really hurt yourself. And then we have to speculate. We have to say, well, if you had sized it right, if you stayed for 2-3 minutes, then maybe your result would be better. But I agree with you that, that there is, there's subtle differences, but again, you have to use the collective data and make your decisions, and we all make, we try to do the best for our patients.
And I don't want to tell you that I think one is better than the other. I think you have the data. I just think it's hard to you have to compare them on other things.
Well, one more question, perhaps we're closing.
I'm John Kahn from Colorado Springs. I'm a surgeon. I think I'm alone in the room here, but congratulations to Dr. Shishehbor and the organizers. This is particularly on the design of the conference with a short presentation, this is really data in the fast lane, and it's been exhilarating. I have a technical question for the panel. How often do you go up and over in popliteal and distal disease, treating that? How often do you go up and over versus going antegrade from the ipsilateral groin straight down the leg? And do you find there's a significant advantage of the latter?
I can start by saying I always try to go from the other side, unless I know there's a hostile problem or the patient is obese or something like that.
I would just briefly say that if I know that the inflow is okay to that ipsilateral limb, and I know I'm going to have to be working below the knee, I almost universally will go antegrade left or right leg, just because I feel like it gives me the best guide support, the best imaging of the lesion, and then I've got all the flexibility to go through the foot if I need to complete the procedure.
I'm exactly like Matt.
I'm very similar. For initial angiography, I almost always go up and over to provide a roadmap of the inflow. If I know that it's almost exclusively infrapopliteal disease, particularly calcific infrapopliteal disease, I'll go antegrade.
I also tend to go up and over, and if I need to work distally, then I'll go antegrade. A lot also depends on the patient. If the patient has a large panus, then it makes it hard to do antegrade and sticking direct SFA. So in those cases, sometimes I'll have imaging from up and over and then work either true pedal.
Yeah, antegrade is when I can do it, definitely go antegrade, and I try to avoid going left to the right as much as possible.
Well, we're going to close up here out of respect for time for the next session. Thank you all for your questions and for your attendance.